Welcome. My name is Dr. Brittany Volk. I am a registered dietitian, a nutrition researcher, and part of the clinical team here at Virta. And every day I'm working directly with our patients on creating and sustaining a low carb lifestyle. And I'm really looking forward to sharing some of that with you here today. I have been with Virta since our early cases of diabetes reversal. And as I mentioned, I work day to day helping patients to sustain this lifestyle. And as a registered dietitian and researcher, this truly is my passion because I've seen firsthand the powerful results this approach has, both in the research and real world settings. To me, having data-driven nutrition recommendations is what we all want for our patients. And on a personal level, diabetes has impacted me, like many probably on both sides of my family. I've seen the complications physically, mentally, and emotionally. And I've also seen the opposite of that in the patients I've worked with. So my goal really is to bring this approach, both the knowledge and the practical tools to as many as possible. So again, thanks for being here and for your interest today. Now that you've heard, the science behind carbohydrate restriction, particularly its effectiveness in treating type 2 diabetes, I'm going to get into just how this can be implemented, both through nutrition and, of course, behavioral change considerations, because this truly is, a lifestyle that patients learn, and it has to be tailored to the patient based on so many factors: dietary needs and preferences, social and religious influences, lifestyle demands, and on and on. And of course, we won't get through every single aspect today, but I hope to at least hit the highlights. So something that I think is important to remember as we think of carb restriction for diabetes, and especially as a registered dietitian, is that, what we're really saying is that food can truly be medicine. We're going to be talking about primarily real whole foods, the right foods for one's metabolism, and being able to provide, greater results than even most drugs can produce. And that's really powerful, especially as we want to empower our patients with the right knowledge. And as Dr. Hallberg mentioned, the ADA has now recognized carbohydrate restriction as a first-line therapy option in treating type 2 diabetes. So it's important that we help our patients get it right, because when we do, it can be incredibly impactful, as Dr. McKenzie presented to you today. And it's worth reiterating that the level of carbohydrate restriction needed for a patient to control their diabetes varies and can range from a very low carbohydrate ketogenic diet to a more moderate but still low in carbohydrates, especially when compared to, our more standard nutrition approaches out there. And tracking one's biomarkers like glucose while making these changes can really help determine what level of restriction is right for each individual. But before we get into the details, let's clarify what a ketogenic diet is not. So a ketogenic diet is not high in protein. It is not just simply a meat and cheese diet. It does not incorporate, simply one style of eating. It is not comprised of all processed foods and low carb products. And low carb is certainly not zero carb. There's a big difference, and you'll see all of these points presented in more detail as we continue through the presentation. Now let's go back to something else that Dr. Hallberg shared with us, which really demonstrates the rationale behind the science-based recommendations of a low-carb approach. After all, diabetes is a problem of blood sugar control, and we're targeting the root cause by reducing the macronutrient that has the greatest impact on blood sugar and therefore insulin levels, and that's carbohydrates, with protein, of course, having a minor impact and fat having none at all. And what that translates into is a plan that is low in carbohydrate, moderate in protein, and high in fat. Now, when I say high, that's for most of us, what we're traditionally used to. Now, logically, if we consider that last figure that I shared and the impact that macronutrients have on blood sugar and insulin levels, it makes sense that a ketogenic or carb-restricted diet contains primarily fat, in fact, up to 80%. And it's focused on saturated and monounsaturated sources. Protein of 15 to 20%, which is really standard nutrition advice. And then again, It's not high in protein. And that leaves carbohydrates with about 5 to 10% of calories from carbohydrates. Now, typically, to achieve nutritional ketosis, one needs to consume under 50 grams of total carbs per day. So that's total carbs. Some will find their tolerance is a bit higher, but for the majority of patients with type 2 diabetes, maintaining their metabolic health requires them to consume less than the 50 grams of carbs per day. And you can see a general breakout here of where those carbs are coming from. Now, I know that the food pyramid is technically a bit outdated and we now use my plate, but I think we can agree that this image is quite familiar to most, if not all of us today. So if we think about the traditional food pyramid with carb restriction, we're essentially just flipping that upside down. Instead of carbs as the majority of calories, fat becomes the primary fuel source. And it makes sense, especially for those who struggle with blood sugar control, since fat has no impact on blood sugar or insulin levels. So now let's really dive into these macronutrients. And I do see questions rolling in, particularly relating to this section. And so I hope to hit most of them actually throughout the presentation, but I will get to them at the end of my section if I don't happen to touch on them or you'd like me to elaborate. So feel free to keep those questions coming. Okay, so first, more about carbohydrates in the context of carb-restricted nutrition. Remember, this is not zero carbs. There's a big difference. And there are many different approaches to carbohydrate restriction. At Virta, we do aim for nutritional ketosis, which means for our patients, the target is 30 grams of total carbohydrates, at least initially. We'll then work with each patient to tailor their carbohydrate intake for their health and help them figure out the lifestyle that they can actually sustain. And the sources that make up that initial 30 grams of total carbs include mostly non-starchy vegetables, your broccoli, cauliflower, lettuce, asparagus, and so on. Some nuts and seeds, full-fat dairy like creams and cheeses, and miscellaneous sources like, say, full-fat salad dressings like ranch or blue cheese. Now, berry fruits can be consumed in limited amounts, though it's recommended not to include them in the initial 30 grams because it's quite easy to overshoot your target if you go beyond those first few items listed here. And what might seem obvious, but I'm going to say it anyway, is absolutely no grains, potatoes, or sugar. Now, remember, the goal here is to gain control of blood sugars. So promptly reducing carbohydrates to 30 grams is a way to achieve such control, which leads to control over hunger and cravings. And when you empower patients to eat in such a way that reduces their hunger and cravings, for many people, they've never experienced this before, you can make it so much easier to help them make the best nutrition choices for their health. Now, to provide a bit more detail on the majority of carbohydrates in that 30 grams, here's vegetables. So it's important to aim for 5 servings of non-starchy vegetables daily. And this is important for several reasons. First of all, mineral balance, as well as they bulk up meals and they provide a really great vehicle for sodium and fat, both of which are critical with carb restriction. Now, I've had patients in my experience, come to me and say, I won't touch vegetables. And I challenge them to try to find a vegetable they don't like once they add some butter and salt. The flavor is so enhanced, and these are game changers. And I mean, people have to like what they eat, right? So we can't simply hand patients a meal plan and make it work for them. This has to be enjoyable, and it is when you choose the foods that you like. And if you think it's impossible to just eat 30 grams of carbs per day, some people are shocked by this number because you compare it to maybe the 200, 300 grams of carbohydrates in the standard American diet. Well, take a look at this. It is absolutely doable. And remember, as patients are doing this, they're getting control of their hunger and cravings because their blood sugars are more stable. And so it is much easier once you begin to make these changes. And I'll point out that this pattern shown here on the screen, and you'll notice the carbohydrates, the grams of carbohydrates are in parentheses, so you can just see how it's sort of spread out throughout the day. But I want to point out that this pattern shown on the screen, it's just one of the ways that a way of creating, a day's worth of food. Patients don't have to follow the old 5 to 6 small frequent meals, because with this way of eating, they're already getting those blood sugars to lower and more stable levels. So if they choose to have 2 meals and no snacks, or 3 meals, or really whatever they choose, that's fine. As long as they track their blood sugars and see those sustained improvements, then that particular meal pattern with those particular food choices, then that's what works for them. And it's really freeing for patients to get this freedom of choice in their meal patterns, and are no longer tied to a clock when it comes to eating. Just remember, as I show you these meal plans, it truly is it's not a one size fits all approach. And here's another snapshot, pretty similar, but if you notice in this one, this is for someone, say, who is a vegetarian who chooses not to eat meat, whether it be for social, cultural, or religious reasons. So this can be done regardless of lifestyle. And I will also make a quick mention that a common misconception is that there's little to no fiber with carb restriction, and that simply is not true, because remember how much I've been stressing those vegetables, and you'll hear it just like my patients hear it several more times today. Also the role of fiber changes as one adopts a low carbohydrate eating pattern. Think of the traditional roles that fiber has in stabilizing blood sugar, in regulating bowel function. Both of these are commonly seen when carbohydrates are restricted. And you can see in this example here that between vegetables and nuts, it is certainly not a no fiber plan. And if someone is looking to increase their fiber intake, of course, the type of vegetables matter, as well as so do the type of nuts that they choose to consume if nuts are part of their plan. Just look at the example between cashews and macadamias. And yes, I know cashews are not technically a nut, but most people tend to categorize them as such. And I wanted to do a quick comparison here. So not only do the total grams of carbs differ here when you're trying to think about staying within that 30 grams, but so do the amounts of fiber. So formulating a patient's nutrition and furthermore helping them formulate what's right for them it's important to consider not only those macronutrients, but also the specific foods that fall within those categories. And let's not forget about fruits that fit into the vegetable category, I should say, that some would often think of as vegetables, but actually fall into the fruit category, the berry fruits we call them. These also provide not only greater variety of food selection, but also a bit of fiber as well. All right. So moving on to our next macronutrient, we've got protein. Now, it's essential to maintain structures and functions of the body that we want to preserve, like muscles, heart, liver, kidneys. However, too much of it can cause stomach upset and inhibits one's ability to efficiently burn fat and sustain a low-carb lifestyle. So it's really a balance that can take some time to get right. Protein needs. This need for protein is largely based on height and gender within a range of about 1.2 to 2.0 grams per kilogram of one's reference body weight. And you can find a deeper dive on this topic in the link you see here on the screen for those of you who are really interested in really diving into protein, because I think this is one of those things where we're just going to touch the surface, but it is such a common topic when it comes to sustaining carbohydrate restriction. And it's a common place where patients really do take, as I mentioned, some time getting used to finding what's right for them. Now, common sources include, beef, pork, lamb, poultry, eggs, fish, cheese, tofu, nuts. And again, how much of these short sources one should consume in a day is based on both their target and their preferences. Now, I will stress the personalization here, because while there is a target amount for each person based on gender and height, there really is a range. And so using blood sugar levels and ketone levels can help guide this personalization to find what's truly right for each person within their target range. And the chart you see here on the screen is, again, that can be found in the post that is linked there at the bottom of the screen. Now, along with biomarker tracking, it's really recommended for most patients to use a food scale to weigh protein portions. It can be super helpful, especially when first getting the hang of things. It's just so easy to underestimate the amount that you're consuming and to overconsume protein sources. I will add that there are some really common, protein-related pitfalls that patients run into. That was a bit of a tongue twister, but as you might expect, one of these includes too many of the easy to grab sources like nuts and cheese. They make great snacks, right? So our eyes tend to gravitate towards protein sources like your chicken at dinner or an extra egg on your morning omelet. The key is hitting your protein target without going over. And what can really help is consuming adequate amounts of fat. This is going to be a key to sustainability because fat is going to be your primary fuel source. Protein's not an efficient fuel source. Like I said, we want enough of it to maintain those structures and functions that we want to preserve, but not too much that it's going to inhibit our fat burning capabilities. And again, I'll stress that the scale to weigh your protein portions can be super helpful to assist patients to understand their protein intake. All right, so moving on to fats, our third and very important food macronutrient. When carbohydrates are restricted and protein is consumed based on your needs, the rest of your calories are coming from fats. And remember, again, fat is your primary fuel source when carbs are consumed below one's tolerance, and it should be consumed to satiety. Now, when weight loss is a goal, a mix of this fuel will be coming from both dietary fat and one's own adipose reserves. As one approaches a maintenance weight, dietary fat may need to be reevaluated and adjusted because, again, always consuming it to satiety. So if someone is hungry, that is an indication that more fat in the diet is needed. Now, the fats to focus on are those you see here. So sources of saturated and monounsaturated fats. What you don't see here are vegetable oils, which are sources high in polyunsaturated fats. The need for polyunsaturated fat is actually quite small, and we can think of it almost as like a vitamin-like amount. So when carbs are restricted and total fat in the diet increases, it's important that the sources of fat to focus on are primarily coming from those saturated and monounsaturated fat sources. Now, in addition to the fats and oils I just showed you, here are some examples of high-fat foods, things like nuts and olives and fatty fish. Now, remember, many of these also contribute to one's protein intake, or avocados will contribute to a carb intake. So we want to make sure that we keep that in mind as we're formulating one's nutrition plan so that we keep carbs within that 30 grams, we keep protein to their target. And so when we think about fat to satiety, we want to be thinking about those previous sources that I shared, the added fats that you'll add. So fat for satiety. Now, I want to point this out. A key to sustaining the lifestyle, I've said it a couple times, is to consume fat for satiety. Well, it's not a free food. So that's important to remember because some people do start this lifestyle and they think that it is just add all of the butter and olive oil that is, that you want. And the truth is you can overdo it. So it's important to consume enough that one isn't walking around hungry all day, like so many are just all too familiar with if they've ever attempted to control their diabetes or lose weight through modifying their food intake. And so this is just another example of where getting enough of the right fats, those saturated and monounsaturated fats, but not too much, is going to take a bit of trial and error and really listening to those hunger cues. And I will say this is an area that probably takes a bit of time, even more so maybe than the protein, for patients to get used to. They have to get used to the idea of troubleshooting and listening to their hunger and getting in touch with those cues, and then also reevaluating it. As a patient has maybe lost 30, 40, 100 pounds, they need to get more comfortable with the idea of increasing their fat intake even more so. And so again, it's always being in touch with that satiety. Okay, so we've covered the food macronutrient categories. Let's move on to the micronutrients because they're important as well, and we really don't want to ignore them. So when we consider carbohydrate restriction, let's start with sodium. The need for sodium when carbohydrates are restricted is even greater. And there's a diuresis that occurs. So it's important to incorporate adequate amounts of sodium by doing the following, like salting foods to taste and supplementing with sources like bouillon or broth or salt tabs or other high sodium foods to make up for those sodium losses. And of course, those taking antihypertensives or who have high blood pressure should be monitored closely because sodium depletion can lead to hypovolemia, constipation, and other issues. And so many people associate these with the quote unquote keto flu that you might have read about on the internet, but realize that these can truly be mitigated or even completely avoided when sodium and fluid intakes are adequate. Another one we like to point out is potassium, and it's common to think of potassium whenever we discuss sodium, and for good reason, right? This balance is really important, and potassium is an essential nutrient, and we need about 4 grams. That's essential for long-term well-being and function. And so this is a major reason why we stress those 5 servings of non-starchy vegetables. They're so important. I told you I would mention them over and over again, and getting patients to implement that is really important, and reminding them of that is really important. Sources of potassium that are low in carb, so forget about the bananas and potatoes, include beet greens, avocado, spinach, and kale, among many others. Another micronutrient to keep an eye on is magnesium. Now, because most magnesium is stored intracellularly, blood tests won't pick up on a magnesium depletion. So the best indication are physical symptoms like muscle cramps and muscle twitches. So if patients report these, a magnesium supplement is often encouraged, as well as a dietary assessment to include more magnesium-rich foods like nuts, avocados, leafy greens, fatty fish, and steak. And I know we're just touching the surface on micronutrient considerations. There's so much more to it, especially when considering medication interference, but this really is a great general starting place for most patients. All right, so we've covered macro and micronutrients in the context of carb restriction, but what about creating a nutrition plan that a patient likes and will stick to? Because that is key to creating lasting health changes. Formulating it correctly is step 1, yes, and that's really powerful, but now we need to consider other factors. What about a person with the sweet tooth, or someone who, say, drinks, yes, a 2-liter bottle maybe of soda daily? I've definitely encountered this in my dietitian nutrition counseling. So cutting those out completely isn't always a realistic solution, as any dietitian will tell you. So let's start with sweeteners, because there are so many questions that come up about this. Whether artificial sweeteners or sugar alcohols, there's lots of questions. And I can tell you that sweeteners aren't a mandatory part of a carbohydrate restricted diet by any means, but do they have a place if they will aid in a person's satisfaction and their sustainability? Absolutely, because the goal, again, is lifelong sustainability to keep diabetes at bay. If a patient isn't going to stick to a nutrition plan and figure it out for the long haul, we haven't done our jobs by helping them, again, to sustain that diabetes reversal. So let's talk about sweeteners and how to handle them. First is education with the patient. Involve them in the conversation. Find out what they're currently doing and what seems realistic to them, and help them decide what is right for them. So some patients are fine, having a bite of something sweet, and for others, it may send them down a slippery sweet slope. So for some, complete elimination might be the answer until perhaps later on into their lifestyle. or perhaps even forever, but they need to pay attention to what is right for them as well as how their biomarkers are responding. Maybe even, a diet soda might be enough for some, and maybe, that person I mentioned earlier who drinks a 2-liter bottle of soda daily, work with them first to cut it in half, and then of course be sure it's diet. Also note that the sensitivity to sweet will change over time. Just ask anyone who's made these lifestyle changes. Having some, let's say blueberries a few weeks or months after adopting a low carb lifestyle, they taste practically like candy. They're so much sweeter. So working with a patient to see what's right for them at various time points when it comes to sweeteners and desserts is really important. As is, adding something sweet, patients will certainly respond differently. As with everything, this has to be personalized. So as I mentioned, using biomarkers, using cravings as guides, know how sugar substitutes, both the type, as I mentioned, and the amount of what the patient is using, how that impacts the patient. I have patients who may, they just need one little sweet thing after dinner and it works for them. It doesn't send them in a spiral. They don't need sweet all day long and it works. I have some patients who, can't seem to get it out of their regimen, after every single meal, and it might not be working for them. Is it contributing to a weight plateau? Is it causing them to crave something even sweeter? So it has to be evaluated. And while I'll say sweeteners should typically not impact blood sugars, I've had patients report anecdotally that they do, and most notably, Diet Coke in particular, patients have reported this, and there seems to be some combination of ingredients rather than the sweetener itself, that some will see an impact in their blood glucose. So again, monitoring is so important. It's all part of that personalized planning. And here's another little clinical pearl, going back to diet soda, because it seems to be a topic that comes up a lot with patients. There's so many patients that use it as a crutch for various reasons, and it's the perfect time to share some words of wisdom around this. And I know there's a lot of controversy about diet soda out there, but think about this. For some patients, diet soda is a crutch, and they're already giving up so much, that's forcing them to eliminate this altogether can just seem like far too much. And if any one aspect of this nutrition plan seems like too much for the patient to handle, it can be enough for them to say, okay, that's it, I'm done. So our goal and our job in formulating their nutrition plan is to also take into account these kinds of considerations. So perhaps instead of saying, okay, cut it out to get all together, or even without saying cut it in half, perhaps you suggest to the patient, okay, it's realistic that you can continue to consume the diet soda, but give them the power to make that decision for themselves, and suggest that, hey, wouldn't it be a great idea if first, before drinking the soda, you have to drink an equal amount of water before the soda? This will automatically help them cut back, but again, you're empowering them to make that decision and not just telling them what to do. And I will say, when it comes to which sweetener, again, it comes down to choice. They don't have to be here at all in their nutrition plan, but again, many people will choose to include them. Naturally occurring sugar substitutes tend to be better than the chemically created compounds, but caution that even those natural ones can be highly processed, so be sure to read the labels. When it comes to sugar alcohols, xylitol, which offers dental protection, and erythritol are generally good options, but another few words of caution. I always like to say this when I mention xylitol. It's toxic to dogs, so be cautious, as well as both are generally tolerated, but everybody tends to respond differently. So if a patient says that just irritates my stomach, then that's not for them. It might be too much for them. There generally is an upper limit of tolerability, regardless of if a patient will tolerate one specific type of sweetener over another. Bottom line, sweeteners are not mandatory, desserts are not mandatory. It's a choice, and it should be considered if it enhances the sustainability of this lifestyle for the patient. Okay, so some lifestyle considerations. Now, this could go probably on for the next 3 hours, but I will touch the surface and get to some of the big things that we run into. So getting the right foods both the macro and the micronutrients with consideration of the actual foods that a patient enjoys are just a few pieces of the carb restriction puzzle. But as anyone who has worked with human beings knows, it's not just about telling someone what to eat. It's not even just about putting meals together. It's about incorporating this into their existing life. And just as we all have a different tolerance to carbohydrates based on a variety of factors, we also have very different lifestyle factors. In addition to medical histories and health goals, there are additional considerations. So, are you a busy soccer dad, always on the go and barely having enough time to do anything extra? Are you a part time student who really needs budget friendly ideas? Are you someone who eats mostly takeout and you don't really want to change this? So, you want to figure out what you can order from where? Are you someone who follows a vegetarian lifestyle and needs to understand how to consume the right amount of protein, which while also restricting your carbs to a level that will help you achieve your health goals? And lastly, I'll give you the example, are you lactose intolerant? So creams and cheeses are certainly not going to be part of your lifestyle. I could go on with these examples, but think about every one of the patients that you've interacted with and their diverse needs. These needs can fit all within the context of carbohydrate restriction. Trust me, I've worked with night shift workers, truck drivers, and others who you might think would make these nutrition changes and lifestyles impossible, but I promise you they're not. The key here, though, is identifying what those potential barriers will be with the patient so that you can work through them together. With the right advice, consideration of the individual, their schedules, their likes, their intolerances, and so much more, this works. And these images here on the screen, these images, using food as medicine, these can help a patient control their diabetes with less or even no medications at all. Food really can be medicine. So knowledge is, of course, critical. But so what to eat and what to avoid and how these foods impacts one's blood sugar, yes, that's important, but also identifying those challenges I talked about. And I wanted to highlight a few challenges that exist for patients because this part is invaluable. In addition to different schedules and lifestyles we all lead, which I touched on a minute ago, here are just a few of the common challenges that really just touch the surface. So some are simple, quick solutions like, many patients tend to experience what we call the carb or protein creep, where just a little bit comes back into their lifestyle. They're, 6 months into adopting a low carb lifestyle, and all of a sudden they're eating double the amount of carbohydrates. They didn't mean to, but they're baking low carb desserts and they're just adding them in here and there. It happens, but it can make a really big impact. So some challenges that arise are really simple to troubleshoot, but some can get a little bit harder. So the key is first identifying the nutrition issue. But then it's important to ask if it's really a surface level issue like that protein or carb creep, or does the issue go deeper? So as with any patient population, some issues can be more challenging, like mindless or stress eating, and getting to the root cause of some of these issues, even if that means an outside referral, can really be another piece to the sustainability of a low carb lifestyle. So again, I stress the individualization. Yes, carbohydrate restriction is a powerful driver of metabolic improvements, but the behavioral support is a key component and it cannot be ignored. Monitoring and self-assessment is important to tailor nutrition advice and behavior modifications to then support those nutrition recommendations. So I'm going to repeat it one more time. So important is support, all kinds of support from clinicians and from those around the patient. So friends, family, whomever they trust. And it's important to help them identify those people so that they can be their allies as they're making these pretty big changes. You can't be with them all the time, right? I remember being an outpatient dietitian. I couldn't hold the hands of my patients. We can't know what they're doing at all times when they're at a birthday party or, celebrating a holiday. You can't be with them late at night when perhaps, mindless or stress eating often comes into play. So support is critical, and also is patience as they navigate their way through this lifestyle. So I can't stress these things enough. And in these presentations, I often get questions about how we support patients and address the various factors of adopting, modifying, and sustaining this lifestyle. Well, I can tell you that it first starts with careful and thorough education with the patient. And meeting patients where they're at, from not even knowing what a source of carbohydrate is to maybe wanting a deeper dive in the science. Patients need to be armed with the right knowledge before making any changes. And as they do make these nutrition and lifestyle changes with us, which, let's face it, change can be really hard, they're tracking their biomarkers to learn how their body is responding. They're getting almost around the clock support from their care team. I like to say that we essentially provide a patient with a health coach and a provider in their pockets to give them the medical guidance and behavioral support to help them meet their goals no matter where they are. We provide this real-time care for every single patient, and doing this through telemedicine allows us to do this at scale. Now, we do this at scale, but with all of the nutrition and behavioral considerations I've discussed, this can be done one-on-one in a clinic, but realize that some patients will just need a little more handholding and a little more and more frequent medical guidance and support. And one thing we've also done, which has been really impactful for our patients, is connect them through an online community. So this allows them to stay connected with their peers and support one another in a way that adds another layer to what their care team already provides. So I'd say that support when it comes to medical, nutrition, behaviors, and peers are all important to the sustainability of carb restriction for patients to keep their diabetes at bay and live healthier and happier lives.